Thank you for joining us today for this webinar about clinical pharmacy services. This webinar is being recorded and the slides will be emailed to you after the webinar has finished. At the end of the presentation, there will be a question and answer session, so just please hold questions for now, and then I will instruct you how to ask your questions at the end. I would like to make note that this publication was made possible by grant number U30CS09734 from the Health Resources and Services Administration, Bureau of Primary Healthcare, and its contents are solely the responsibility of the authors and do not necessarily represent the official views of HRSA. This webinar is titled Improving Health Outcomes of Residents of Public Housing, Integrating Clinical Pharmacy Services. Many health center programs, patients take multiple medications, and Dr. Ramirez and Terry Lawson, they'll be talking about how these individuals are prescribed multiple prescription medications for either one disease or multiple diseases, and that over the course of time, while they're taking these prescribed medications, they can start taking over-the-counter or herbal medications as well. And this can be a safety risk for any individual. And Dr. Ramirez and Ms. Lawson will discuss the important tools and methods to educate your staff and public housing residents on the importance of adhering to a medication schedule for whether it's a prescription medication, an over-the-counter, or herbal medication. Dr. Ramirez is the Chief Medical Officer at Sioux Falls Health Center in Dover, New Jersey. She has been at Sioux Falls for nearly 6 years. Since the beginning, Dr. Ramirez has been team lead of the Diabetes Collaborative at Sioux Falls Health Center. She has been working with several other HRSA collaboratives, including the Patient Safety and Pharmacy Services, to address health disparities by developing innovative approaches to diabetes care. Terry Lawson is a clinical pharmacist at Sioux Falls Health Center in Dover, New Jersey. Ms. Lawson is also a certified diabetes educator. Dr. Ramirez?
Well, thank you, Tricia. Hello, everybody. Good morning and good afternoon, depending on where you are. And thank you for joining us today. We're going to share a few things that we've learned over the past 3 years about how to help patients in all walks of life, but especially those in public housing, deal with the multiple medications and their conditions and how to get better medically and feel better and also reduce their side effects from their medications. So let's start. And there we go. So our learning objectives are listed in the slides. The first one is to list at least 3 ways in which the clinical pharmacy services, which is the program that we'll be discussing with you today, can help identify patient barriers to improve their health. So that things that will may be a barrier to them are then sort of taken care of, and then they can get better. Name at least 2 tools that the pharmacist and the patient can use to improve adherence or their ability to take the medications as it is prescribed. And finally, describe 2 ways in which clinical pharmacy services, or CPS, can help control polypharmacy, and we'll define that for you. I'm going to speak for the first 1/3 of the lecture, and then the last 2/3 will be Terry, who really does all the clinical pharmacy services and can really provide you with a first-hand view of what really happens in the exam room. But a little bit about us. Sioux Falls Health Center is located in Northwest New Jersey, and in this slide you see it's in the bluish side. That's the areas that we, the counties that we are serving. It was established in 1990 as a volunteer-free clinic by Dr. Sioux Falls and his wife, who saw the need in their own backyard. They actually volunteered to go to Peru and other underserved countries, and then they saw, well, we can do it right here. And after they retired, they actually began their clinic in a basement church with volunteer physicians, friends of theirs. And it really grew into what we are today. We became an FQHC in 2004. That's a federally qualified health center. And we expanded to 3 sites in a mobile van in 2008. we became a public housing residence community service area in 2009 when we opened our Morristown site. And we also serve the homeless. We serve special populations for farm workers. And, of course, we serve our community. We're open 7 days a week. We have early morning hours and late hours so that we really can provide access to care to all our patients. Our services are many, and that's why we pride ourselves in being a one-stop shop in terms of our services. And it also, again, enhances access to care and coordination of care to our patients. We have mostly a Hispanic population. 72% of our patients are Hispanic, so we have to provide bilingual services. And our staff, especially the medical assistants and the staff, speak both Spanish and English. As you see, our services include pediatric, adult medicine, women's health, and dental. And we just recently got Ryan White funding as well. We have other subspecialists like podiatry, behavioral health, and neurology. And we're very proud of our clinical pharmacy services, and that's what we're going to talk to you about today. This is our 2012 data from our UDS, and we've served over 16,000 patients and had over 50,000 visits last year. As I mentioned previously, 70% of patients, or 80% of patients, were racial and ethnic minority groups, and the majority are Hispanic, but 94% of them are under 200% federal poverty level. So we really are serving a community in need. 72% of our patients are uninsured, and this poses some difficult access issues to our patients, especially when they have to buy more than a few medications, and they have to get lab works and other diagnostic testing. We have mostly adult patients. We see 72% of our patients are adults, and then we have 22% of patients that are children. And of those, only 52% of our children are insured. So we actually have quite a large migrant group of children. We have 540 patients who are residents of public housing last year alone, even though we've seen over 900 patients who are residents of public housing since we started providing services in 2009. So what is clinical pharmacy services? It started first as a concept when we first joined what Tricia mentioned was the Patient Safety and Pharmacy Services Collaborative in 2008. And this was a HRSA-sponsored program that is still going on today. It's going strong in its 5th year. We didn't have a pharmacist then, so we decided to PDSA, or Plan, Do, Study, Act, do an improvement plan around what we were doing involving our contract pharmacists, because we have a 340B contract pharmacy, and we use brown bags at the health center, and Terry's going to talk to you a little bit more about that because we're still using it today. We hired Terry in 2009 as we saw that the need for the clinical pharmacist was really very, very, very key and important for us to provide special services to our population of highly uncontrolled or difficult to control patients with diabetes, high blood pressure, high cholesterol, obesity, HIV, and anticoagulation. We served over 1,000 patients since we started this program, and we've improved consistently every year their health and their safety outcomes by 67%. That means that they were all out of control when we first started, and only 34% are still not quite there, but we've had the majority under control. So we're very proud of that. This program further was evolved with our participation in Project Impact Diabetes, a foundation program, APhA foundation program that helped us really designate that and determine that what we were doing was clinically significant. And we were very excited about this. And Terry, again, will speak a little bit about that at the end of the session. So how do we provide clinical pharmacy services? This is Terry with one of our patients. And essentially what happens is that the patients are identified by the providers as high-risk patients. They have multiple conditions, out of control conditions like diabetes, very out of control, high blood pressure. They refer to Terry for her to have a one-on-one conversation, discussion, and educational session to make sure that the patient understands and begins to manage his condition in a way that he can understand. It actually involves frequent follow-up visits, and she will talk about the whole process a little bit further on. Terry's only with us part-time, and she's involved in other activities as well, but she's definitely part of our team. Now I'm going to turn it over to Terry so she can talk to you a little bit more about clinical pharmacy services. Terry?
Thank you. Thank you very much, and it's a real honor to have the opportunity to share clinical pharmacy services with you all. And just to start off, there are at least 10 components of clinical pharmacy services, but for the purposes of our discussion, I selected 4 elements that I believe are the nuts and bolts of doing the process with the patient. The first one is prospective chart review, and basically that's getting to know your patient better before even meeting them in person. So it's really the beginning of getting to know the big picture with respect to that patient. The second one is medication reconciliation, and that's basically work through interactive tools that really engage the patient in the process of reconciling their medications and keeping them safe. The third one is medication therapy management, which is really individualized assessment of each and every medication, over-the-counter supplement, herbal medication, alternative medication that the patient may be on, is individually assessed. And the fourth one is disease state management, which is really an inclusive process that includes self-management of the patient. We want to educate the patient on how they manage themselves, and it really brings forth the collaboration of the clinical team. So let's talk a little bit more about prospective chart review. Like I said before, it is the big picture, the start of the big picture of getting to know who the patient is. In that first chart review, you want to see, well, have medications been reconciled in the past in the chart? Is the list complete? Is it different at different encounters? When that gives you a clue that there's some confusion going on with the patient's medication list. It also identifies polypharmacy. Is the patient on no drugs? Is the patient on 2, 5, 10, 15? So it gives you an indication of how much risk the patient is on, is in right from the beginning. Gives you a little look at what the patient's history is like. Are they a smoker? Do they drink? Do they exercise? Have they had diabetes or hypertension or hyperlipidemia, high cholesterol in the past in their family history? Are there any adverse drug events reported within the patient chart at all? Usually there are clues that something's going on with a patient when you see in the chart, felt faint, got sweaty, fainted, fell. All of these things can cue you in or give you some red flags to really focus on when you do meet with the patient. Another great tool that is available through the electronic medical records is the lab review. Being able to have access to the electronic medical records is key, and I think that that's important to point out. Because I have access to the patient records, I can really start to establish a big picture. Back to the lab review, however, that gives you a really good clue or red flag as to whether the patient is adherent. Is he stable? Is he getting worse? Has he gotten better? All of these are clues as to whether the patient needs clinical pharmacy services and focus on education with medication. Another issue that can start to develop is who is the patient really? What are their cultural beliefs? What's their belief structure with respect to their chronic condition? Being culturally competent is essential, especially in using language and respect with that patient before you even meet them. You have to really get a hold of, what their culture is, what their belief structure is, and that gives you a really good starting place before you meet the patient. And of course, the health literacy level is an issue as well that you may find clues in the chart about. Okay. All right, so medication reconciliation. This is not just making a list of what patients may be taking, but it's more of an interactive engagement between you and the patient. And here in Dufil Health Center, we have found that there are a few tools that we have used repetitively, and we find it to be very useful in reconciling and helping the patient reconcile with you. Is the brown bag, as Dr. Ramirez mentioned a little while ago. I'm going to go in deeper into that. An adherence sheet, pill boxes, and good communication techniques. Predominantly, you want to keep them at a level that the patient understands you. So the brown bag, here's a picture of it. It's not brown. I know it's not brown, but it is colorful. Patients are basically told to bring in their medications, their vitamins, their herbals, whatever they're taking, they're told to please bring them in the bag for their next visit, whether that visit is with me or with a provider. It really doesn't matter. It's important to start getting the patient used to giving us access to what they're actually taking and bringing in that brown bag. What is so important about the brown bag is that it's really an excellent tool to discover barriers that the patient is having. For example, if the labels are in English and my patient is Hispanic, as most of our patients are, and I know that they don't speak English, well, that's a barrier, and it brings a question to me is like, how does this patient know how to take this medication? And if they really don't understand the label, well, how are they taking the medication? So it really does identify some barriers that the patient may have. Perhaps their understanding on the refill process. We find that many of our patients don't understand how to refill a medication, and when the vial finishes, they'll just won't get it again. So that's a big issue with adherence. Another thing that will clue you into a patient's non-adherence is if they're bringing in empty vials or vials that have really old dates on them. Just to, they might think that they're bringing it in, see, I'm taking it, but in fact, they're not taking it, and that's something that you can identify and ask the patient, well, what's the issue with this medication? Perhaps you have some side effects, and then you can engage them in a dialogue. You can also get clues as to the literacy. Most of my patients, by and large, will admit to me after the trust has been established that they have problems reading. So those are also barriers that can be identified through the process of using the brown bag and medication reconciliation. You can also find out what the patient's attitudes are with respect to the pharmacy. Many folks are intimidated by the pharmacy. A lot of pharmacies, the pharmacist is in the back of the room, or they're standing about 10 feet above you. It's a pretty intimidating process, especially if you come from another country and the whole process is alien to you. That could be an issue, so that's important to identify that, and the brown bag does help do that. So other things are what are they really taking? I have many patients that, again, they come from different countries, but they also travel back and forth, and you discover that they're taking medication that's not even on their list, that they're bringing back because somebody gave it to them in Honduras or Colombia, and they were told to take it. So it's important to find out what is the patient really doing with their medicines. What are they really taking? Another thing you can zone in on are there any physical disabilities? Diabetics, they have an issue with the risk of blindness, and if they're having issues seeing, they're not going to be able to know or really have within their grasp the ability to read a label. Or if they're using insulin and they have dexterity issues that haven't been addressed or even, realized, they might not be injecting the insulin because of that issue. And of course, the biggest, the best thing that you can get out of the brown bag is patient safety. That's the whole idea behind it, is my patient safe with the medications that they are on? Have they suffered any reactions, any side effects? Are they taking them? All of these can be assessed during the brown bag process. And it's an interactive tool that, more importantly, engages the patient to partner with you. And it's very patient-centered, and we still do it today, and we will continue to do it. This is the adherence sheet that I was talking about. This tool is great to use in combination with the brown bag, because once you may not use it the first visit, the second visit when the patient brings in that brown bag again, you can sit down with that patient and you can say, okay, here's the metformin. What is the metformin for? How do you take it? And they can teach back to you what you've taught them, so that you can have a better assessment of what level they're on. Where is their comprehension? So if they make a mistake, you have the opportunity to say, well, it's better if you take it here. And when you fill out this form, it's more of it sticks to them. They remember it better. And also it serves as a take-home tool for them that they could, put on their refrigerator door or put it where they have their medication, so that they're constantly reminded on how to take that medication safely. The other tool that I use in combination with the brown bag and the adherence sheet are the pill boxes. Pill boxes, in my opinion, are best used for patients that have cognitive issues, that have issues with their memory. It helps the caregivers as well if they have family members or spouses that are actually taking care of them. It gives them a great tool to keep their loved one in check with their medications. And it also serves to sort of simplify a complicated regimen. I had a gentleman the other day that was on, 14 medications. And when we filled the pill box, it made him realize, well, this is doable. I can separate this by, 6 to 8 hours. I don't have to take them all in one shot, which many patients tend to do. They figure they'll take them all at once and they'll do their job from the beginning of the day, and they end up hurting themselves. We also constantly have trainings on health literacy and cultural competency in Zufall Health Center. And we have this little flyer in all of our clinical staff areas to constantly remind them that we need to ask our patients open-ended questions. Instead of asking them, do you have any questions, we'll ask them, what questions do you have? Or in your own words, tell me how you take this medication, which is basically what I do with the adherence sheet. But in addition, we also support our clinical staff to help remind them that health literacy is integral in helping our patients take their medication safely. So medication therapy management, a little history about that. back in 2003, the term was coined by CMS for Part D Medicare recipients. And in 2005, the Joint Commission thought it important enough to name it a National Patient Safety Goal. The problem back in 2005 with the Joint Commission was that it had 17 elements to follow for medication reconciliation, which most people found it rather unsustainable, and it really wasn't a process that could be duplicated. Then in 2010, the APhA, the Affordable Care Act, has provided grants to actually implement NPM services at your facility. And in 2011, the Joint Commission revised that National Patient Safety Goal to only include 5 elements. And that's the system that's in place today, and it's a lot more reasonable, more realistic, and definitely duplicatable. And in 2011, the NCQA, Patient-Centered Medical Home Initiative, actually incorporated it into its standards of comprehensive medication management. So that's a little background on medication therapy management. So what does it actually do? Medication management really is taking a look at each medication for that patient. So is it appropriate for that patient? Does the patient actually have an indication for the drug? Is it effective? Is it working? Is the patient getting better, or are they getting worse? Is it safe for that patient? Are they, for example, having low blood sugar reactions from one of their diabetes medications? If that's going on, then that drug needs to be taken a look at. Are they taking it right? Is it safe for that patient? And is it also acceptable for that patient? A lot of patients have issues swallowing. If the drug is very big, as is the 1,000 milligram metformin is a huge pill, if they're having trouble swallowing that, then more than likely it's not acceptable for that patient, and it can cause non-adherence. So those are the things that medication therapy management are looking at and helping the patient to address their barriers. So again, how does it help our patient? It's patient-centered. They're the focus of the process. Obviously, if the patient, you can prescribe whatever you want to the patient. If the patient doesn't understand or doesn't accept it, they're not going to take it. So you need to partner with that patient. You need to develop trust and respect and an ongoing relationship with that patient. That has been proven to improve the outcomes of those patients. It's a comprehensive approach. So you're going to look at everything that the patient is doing, not just look at the individual drug and say, okay, you're supposed to take it like this and you're supposed to take it like that. But no, find out why the patient is doing it that way. Do they understand what the medication is doing for them? So what are their special medication needs? I mentioned earlier, they may have dexterity issues. If they're on insulin, well, you may need to change them over to the pen instead of drawing a syringe. And most importantly, and I think this is the most important aspect of medication therapy management, is collaboration with the clinical team. Through the process of identifying barriers, those are the dialogues that open with the clinical team to talk about the patient and come up with a care plan for them that fits that patient, improves the adherence, and therefore improves the outcome. So you're identifying these barriers on an ongoing basis by meeting with the patient with frequent follow-up and going through the process of medication therapy management with that patient through multiple visits. Another element of CPS, which goes hand in hand with NPM or medication therapy management, is disease state management. It's basically a focus on the medications through dealing with each individual medication and how the patient is managing certain aspects of their life with respect to that medication. It really starts to clear up what's in it for them. So you're empowering that patient to say to themselves, well, gee, I never understood why I had to take this drug, but now I really want to take it because I understand that it's saving my life. So self-management improves with patient comprehension. It gives the patient the whys behind the aspects of why is this person bothering me about this. They'll understand why we are constantly harping on healthy eating, for example. If you don't take metformin in conjunction with meals, more than likely it is going to affect your stomach and your gastrointestinal system. Also, a good nutritional and healthy lifestyle is going to improve your condition and work well along with your medication. Problem solving is actually explaining the pathology behind the chronic disease with focus on the medication. So what exactly is the medication doing to help me with my chronic disease? And it's almost like an eye-opener moment with me and my patients because they get it. They understand, okay, well, if I take this medication right, it won't hurt my stomach, and it's going to save my life with respect to diabetes. Healthy coping. This is something that in chronic diseases is very common to see people suffering from depression. Depression can in turn affect how the patient self-manages. Are they motivated? Do they feel that their life is over because they have this chronic disease? So healthy coping is a very good module, in my opinion, because if the patient is not motivated to self-manage, is clinically unable to face their disease, then that has to be addressed before anything else and brought to the attention of the clinician. Monitoring, of course, is not just for diabetes. It's also linked to every single chronic disease. We need to take the labs, and in many cases we have issues with outstanding labs that patients don't come in to do them. And obviously that's a big issue when it comes to drug safety. So I help them to understand why we ask them to come in for labs every 3 months, every 6 months, because the drugs have to leave the body one way or another, and we have to make sure that every organ that's responsible for that metabolism is healthy. And not to mention the risks and consequences of uncontrolled chronic conditions can do havoc to those organs as well. So that's also an opportunity to teach any patient why monitoring is important with respect to medications as well. And then you can get into better screenings with teaching them about reducing the risks associated with chronic diseases. So this module, really, this curriculum, I find it to be very, very comprehensive, very useful in identifying patient barriers, and I recommend it and I love it. I think it's been very helpful to me in my practice as well as to my patients, because if they comprehend what's going on in their bodies, and they're more willing to take their medication, and that will equate to adherence to all the aspects of self-management. So in a nutshell, what are the problems associated with polypharmacy? You're looking at patients that are taking multiple medications. We're looking at 5 or more. There are different definitions of polypharmacy across the web, and you could find 6, you could find 7, but for our purposes here, we feel that 5 is a good number. It's also important to note that polypharmacy is not just taking 5 or more drugs. You could be on 2 drugs. If one is inappropriate for you, then that counts as polypharmacy as well, and it needs to be addressed. It's very common in our older population. 40% of those over 65 are usually on multiple medications because they have multiple issues that have to be managed. So the risks associated with the medications increase with the more drugs that the patient is on. So you do see an increase in the rate and severity of the adverse drug events, and that's what APhA stands for, by the way. So you might have some more risk of drug-drug interactions. You may have an appearance of poor adherence because the regimen is too complicated, the patients forget. You also have to look at the cognition and mobility of that patient and what drugs are they on that can be contributing to that and maybe increasing their risk of falling. It also increased the cost to healthcare and to the patient. And generally speaking, if it's not managed well, you're looking at poor patient outcomes. So Dr. Ramirez mentioned earlier that we were involved in the APhA Foundation Project Impact Diabetes, which was part of the rollout of Together on Diabetes, a big project with APhA Foundation. We had some significant improvements. We just received these data sets about a couple of weeks ago, and truly, that Project Impact, what it measured was the pharmacist involvement on the team and how that would improve the outcomes of our patients. We ended up with 84 patients. I met with them an average of 4.2 times. Their A1Cs dropped by almost a point. Their blood pressure dropped by 3. Their LDL dropped by 4.8, and their triglycerides saw the most significant drop of 24 points. More importantly, it improved the rates of the screenings because since it was a more structured program, very similar to the AADE 7 self-care behaviors that I showed you at the prior slide, it was very structured and everything was addressed through multiple visits. So we were able to screen them for foot exams, eye exams, vaccinations, etc. So they really had very, very good outcomes in these patients. So I want to talk a little bit about J.O. He's one of our public housing patients. He's a 63-year-old Hispanic male. I first met him in 2011. He was taking 5 medications plus additional medications that weren't even on his list, either over-the-counters or other medications that family members had given to him. He has multiple conditions. He's got diabetes, he has hyperlipidemia, and he has glaucoma. And he also has a physical disability due to an accident he had many years ago with his hip and his back. And as a result, when I met him, he was completely non-adherent, very, very aloof about his condition. He had denial. He was also confused about his medications. He had many cultural barriers, and his home environment is really the main source of his stressors when it comes to his self-management. And he also had some low literacy levels when I met him. When I first met him, his A1C was 7.9%, and his LDL was greater than 130. And his pain was definitely uncontrolled, which was a real barrier to helping him get physically active. But to date, an update on Joe is that his A1C is 6.5%, and his LDL is at goal. I would meet with J.O. multiple times until he became better at self-management. There were many consultations with the provider and collaborations with the team to help him stabilize his regimen, and today he's doing very well. Another patient is MJ, 47-year-old white male. First met with me in 2011. He was taking 6 medications. He had multiple conditions, diabetes, lipids, schizophrenia. He was a smoker, a recovering alcoholic. He was recently released from prison when I first met him, and he lived in a single room where he only had access to a little freezer and a microwave. And he was non-adherent basically because he just did not know the benefits of the medications he was prescribed. So his A1C was way out of control when I met him. It was 10.2%, and his triglycerides were really, really up there at 865. So his barriers, basically, the gentleman was living in a single-room apartment, had very, very limited exposure, limited financial means to eat healthy. But what he did was he started to get frozen vegetables and frozen lean cuisines and Weight Watchers, and he was very ambitious to, really getting himself healthy. By April of 2011, he was completely alcohol-free. His A1C was 6.1. His triglycerides had dropped to 202. And in May of 2011, he actually had quit smoking, and his diabetes medications were able to be discontinued and his regimen simplified. His A1C today is at 5.2%, and my next follow-up with this patient is in August of 2013. He never ceases to amaze me. He was able to get into public housing after this, and he's done very, very well since. And I want to thank all of you for listening and for being on the webinar. And if you have any questions, please feel free. There's our contact information. You can call us. You can email us. And if there's anything we can do to help, we're more than happy to do so. So thank you.
Thank you, Dr. Ramirez. Thank you, Terry, for today's webinar. That was a great presentation. If anybody has any questions, I'm sorry, please, you can either put your question in the box and to ask your question that way, or you can raise your hand if you have dialed through your phone and would like to verbally ask the presenter a question. Just raise your hand in the icon on your control panel, and I will unmute you if you have any questions. So let me see if there's any questions here. So either Rena or Dr. Ramirez or Terry, if you could answer this question, how easy is it to get the patient's family members involved in their medication adherence?
Okay, I wouldn't exactly define it as an easy process, but I would define it as a doable process. Most families are busy. You know, they go to work, they have kids in school. So it is not an easy process to get them involved. But the way that I've done it is I constantly bring it up. I constantly bring up the fact that, you know, the family is important, that, you know, if I'm speaking directly to the patient, I'll say, you know, it's important for your family to support you. Have you explained your condition to your family? Does your family know? You know, you discover all these barriers because some people are embarrassed to say that they have something wrong with them, particularly Hispanic males. You know, you have to understand that their culture, they're the head of the family. It's really, for them, it's a pride thing to admit that there's something wrong with them. So the education process will show them that, hey, you know, doesn't mean that you're any less the head of the family, but if you have your family with you, we can work together as a family and take it from there. A lot of times if the patient has a language barrier, they'll bring a member of the family with them, in which case you take advantage of that opportunity right then and there and engage the family in what's going on in the household. Because obviously the more information you have, the better off you are at helping the patient. Is that good?
Yeah, no, that's great. That's fantastic. And when you're reconciling the medications, do you try to look at the medications to see if you can change it so there's less medication, or to combine if there's a combination medication out there? Do you try to do that to help with decreasing?
Yes. If I'm managing, for example, the diabetes, let's say that the provider starts them off on Lantus. All right, they're going to start them off at a very low dose, and then they refer the patient to me for education, and depending on where that patient is, I can teach them how to self-titrate that insulin. If, for example, that same patient comes back to me a month later and they tell me, you know what, I've been taking my glipizide and I'm using the Lantus and the metformin, but I noticed that I'm getting really shaky in the afternoon, you know, and it always happens after I take the glipizide. Well, it may be that that patient has reached enough control with the metformin and the Lantus to start looking at that glipizide. Maybe it's time to either reduce the dose a little bit and have them come back and follow up with the provider. Because I'll never say to them, don't follow up with the provider. What I'll do is, in the interim, I'll take care of that issue with that patient and say, you know, if you don't eat, don't take the glipizide. Maybe reduce it to half a pill. I'll also address how they're taking it, of course. And I may adjust how much they take and tell them they have to follow up with the provider at their very next available appointment. So the provider can then have an opportunity to assess that treatment. And then I'll also consult with the provider to see what's the best medication plan for this patient. So it's sort of like a fluid, ongoing process that involves the patient and the clinical team.
Yeah, this is Rena, Tricia. I also want to interject a little bit. In some states, the pharmacist has a little bit more laterality or leeway to do some adjustments and changes than others. But it doesn't mean that even if you don't have a collaborative agreement in the state, that the pharmacist doesn't have access to the physician or the provider. And in cases where the provider is not available and Terry has a question and we think it's important, she reaches out to me or to another one of the providers who are working on the team with the patient, so that things can be taken care of even at that same visit that Terry is with the patient. So yes, we want to simplify it. We really count on her to look at ways in which we can make things easier and better for the patient, and there's the constant communication and collaboration makes that really happen.
Right.
Excellent. Well, I don't have any other questions that have come through. So it looks like we can get off early, we can end the webinar early, unless there's anything that Dr. Ramirez or Terry you would like to add about your presentation.
Well, this is Dr. Ramirez again. If anyone has any questions or any ideas on how they could use even some parts of what we've given out today in their own practices or with their own patients, we're very happy to share. I think that everybody is dealing with similar circumstances, with similar issues, and if we do share what has worked and maybe put it into place in another setting, it might actually work, or you might even come up with something even better. So we look forward to any communications from anyone out there as well.
And one last comment that I want to make is that I'm not sure how much this is out there for people to know, but events due to drugs in the United States, the World Health Organization has estimated it to cost us $200 billion annually. It's not a small problem, it's a big problem and a preventable problem, and I hope that through presenting and putting our system forward, we can make a positive impact on reducing that figure and keeping people out of danger.
Dr. Ramirez and Ms. Lawson, thank you very much for your expertise in this very important topic. Patient safety should be the utmost for everyone in any healthcare setting, and this was an excellent topic for clinical pharmacy services. I would like to thank everyone for participating in today's webinar.